Hello. Okay, can I have your attention, please? Good afternoon and welcome. My name is Deepak Malhotra. I'm the President and General Manager of ScottCare. I would like to take this opportunity to welcome you to this very important educational session. Hopefully you'll enjoy it. As many of you probably know, that ScottCare has been in the business of cardiopulmonary rehab for over 25 years. And since our inception and our humble days in early 1990s, we have made a lot of progress, come a long way, and it's only made possible through our partnership with many of you in this room today. So I'd like to thank you for being here and being a supporter of ScottCare over the years. Of course, our work is not done. We have to advance the field of cardiopulmonary rehab further, and I look forward to our continued partnership. Today's session is going to be moderated by Dr. Ken Sparks. Many of you probably know him. Dr. Sparks is an associate professor and the director of Human Performance Lab at the Cleveland State University. And so he's going to take us through the rest of the session. So without further delay, I'll turn it over to Dr. Sparks. Thank you.
Thank you and welcome everyone. This coming to New Orleans this year was very special to ScottCare. And I'm the only one with ScottCare that's been through all of this, but back in many memories, especially here, of the ScottCare in New Orleans, because this is where it all started. Back in the late 1980s, we developed the ScottCare system. Back then it was called the Tele-Rehab Gold System. Some of you actually probably had the original Gold System. And it was back in the last time the AACVPR was in New Orleans was 1989. And it was 1989 that we first introduced the ScottCare Tele-Rehab. And I remember that show very well because we had like one little table and two signs in the system. And I think we had about 3 people that stopped by to see what it was all about. But so this is very meaningful for us. It was very different then, and we didn't know that the ScottCare system would develop as it did throughout the years to become the leader in cardiac rehab and pulmonary monitoring. So it really has evolved tremendously. And it's evolved or progressed because of all of its users. We listened to everyone. The first system was made around my program, and obviously everybody else did different things than what my program did, so you had very good ideas. And so we started modifying it to where it is today. And we're still listening. If you stop by our booth, we ask for your ideas. We're still developing and progressing the system, and we want to make it to meet your needs. And that's the intention of ScottCare. So the success that ScottCare has had belongs to you. So I thank you for that. Well, getting on with our program today. Today we have 2 outstanding pioneers in cardiac and pulmonary rehab. And they're going to speak to you today. And I've known these people for a long time because they go back as long as I do. And so I'm going to first tell you a little bit about our first speaker, who is Barbara Flato. And she's got a lot of numbers and name or things after her name there. You can see them on the screen. But Barb is a registered nurse completing her BSN in 1976 and her MSN with emphasis in integrative health in 2007. She's been director of cardiac rehabilitation services for Christus Spohn Health System with facilities in Corpus Christi, Kingsville, Alice, Texas, for over 20 years. Barb has worked in cardiac rehab since 1978, establishing programs in both physician-directed clinics and hospitals throughout the United States. She's been a fellow in the American Association of Cardiovascular and Pulmonary Rehabilitation since 1993, is board certified in cardiac rehabilitation through the American Nurses Credentialing Center, through AACVPRs as a certified cardiac rehabilitation professional. She's been actively involved on the local, state, national level, promoting cardiac rehab for over 30 years. Barb was a member of the founding board of CSCR in early 80s, a member of the founding board for the Texas AACVPR affiliate in 1990. She's presented in numerous state and national conferences and currently serves on the AACVPR Program Certification Leadership Team as the remediation chair. And just yesterday, she is a proud recipient of the AACVPR's 2016 Distinguished Service Award and a dedicated Scott Carrier user for 20 years. So at this time, I'd like to introduce Barb, and she's going to talk to you about ITPs.
Well, good morning, and I have to say thank you to Scott Care for having me talk today. And I would have to say that if you're not a Scott Care user right now, then you really need to be, because they have the best parties at AACVPR. How many of you guys got to go to the party last night? Was it fun? I agree. I had so much fun that I split my lip last night. So, and I'm really not quite sure where I was when I did it. And I bet you there's a few of you guys in the room kind of along with me. So anyway, but I'm here this morning and I'm wide awake. And so we are going to talk, Connie and I are going to talk about the ITP. I think I live, breathe, and die through the ITP. We're going to just talk about what the requirements are. We're going to look at the framework, and we're going to look at the future. Okay, so first, why we have an ITP. And there's 4 reasons we have an ITP. First of all, it's a requirement of the government, and we have to abide by what the government tells us to do. Well, we should abide by what the government tells us to do. It's also a program certification requirement. So you don't have to be certified, but if you want to be certified, you have to have an ITP that fulfills all the elements that we require. The 2 last things are the most important reasons why we have an ITP, and the real reason we have an ITP, because we need to have continuity of care for our patients. We need to do that handoff. If somebody else is coming in to care for that patient, they need some kind of a quick form document to look at to find out where that patient's been so far in their cardiac rehab journey and what they need to do for the day. And then the last point goes to, if you hear nothing else today, this is what you need to know. That ITP has to be a document that shows what happens to the patient from start to finish of cardiac rehab. It has to tell a story. It has to tell the journey that that patient's been on for the last 12 weeks. So we're going to just look closely or quickly at the requirements for the ITP for cardiac. And my colleague Connie is going to talk about pulmonary. So for cardiac, this is what CMS requires us to have in our ITP. And some of you might think that we sit around at the leadership team at program certification and say, what can we do to make this harder for our colleagues out there? And that's not what we do at all. We have to take what, number one, the government tells us needs to be in that document. And we also have to look at what the resources that we have. Our expert panel, we have both cardiac and pulmonary expert panels. They are the people that do all the research, and they're the ones that give us that evidence-based medicine as to what we need to look at. So what should be in that ITP is, and cardiac difference is that it puts in risk factor modification. Okay, so we have to have a physician's prescribed exercise. We have to have the risk factor modification. We have to have a psychosocial assessment. We have to have outcomes from day one to the end of cardiac rehab that tells the journey. What are those outcomes for the patient? How did they do in cardiac rehab? And then it has to be signed by the physician every 30 days. Okay, so let's get a definition. A physician-supervised program that furnishes physician-prescribed exercise, cardiac risk factor modification, psychosocial assessment, outcomes assessment. That's what we just said. Okay, that's CMS's definition of cardiac rehab. What needs to go into the individual treatment plan? The diagnosis, the prescription, the exercise prescription, which is why now, starting next year with program certification, we're only going to look at the ITP to evaluate your exercise prescription. CMS requires that it's in the ITP, okay? And then the goals that are set for the patient. Okay, so what does program certification then require? Well, guess what? It's the same thing that CMS requires. Okay, so we have it maybe in a little different format, and in my thinking, it's a little bit easier to understand. You need to have nutrition, you need to have exercise, you need to have psychosocial, you need to have other core components or other risk factors. So that's what you have for each element. Now, for each one of those elements, you have to make sure you have an initial assessment, and from that initial assessment, you're going to develop a plan. Okay, so you have to have an assessment, you have to have a plan, and within that plan, you're going to have your goals for the patient, and you're going to have your interventions. What are you going to do for that patient in order for them to reach their goal based on their initial assessment? Okay, pretty easy. And then you're going to have a reassessment whenever. Now, you're going to hear every 30 days. You're not going to reassess every 30 days. In my program, we reassess every day, and I think you do too. When the patient comes in, have you taken your medications? Have you had any pain? So those things you're reassessing every single day. And I think that there's a general feeling out there because the physician has to sign every 30 days that that's when you're reassessing. Not true. So have an ITP that is a living, breathing document that you're using every single day. It's not an obligation that you take out every 30 days. It's something that you use to guide the patient's care. So again, just an example of these are the steps of that you're going to take with your ITPs. And just another way of showing. Okay, so what does the ITP look like? Okay, that has all of these steps in it. This is what it looks like. A little difficult to see, but I'm going to try to. I wonder, is this yeah, okay. So we have exercise, we have nutrition, we have psychosocial. This just happens to be the newest version or coming out version of Scott Care's, and I'm not prejudiced or anything, but this is the newest one for Scott Care. They have two that's coming out. One that is like this, that you're going to click off whether it's a 30-day ITP, 60-day, 120, or initial assessment. It's 2 pages long, so very easy, and it's going to be built into the system. So you've got exercise, nutrition, psychosocial. For exercise, you've got the prescription right there that gives you all of the elements that you need for an exercise prescription: mode, frequency, duration, intensity, and very smartly they left progression in there because I think it's going to come back. And then you've got what the home exercise is, the nutrition, psychosocial. Okay, and here's your other core components. Okay, so it's 2 pages that you're going to fill out you're going to fill it out every day as far as I'm concerned, but this is what the doctor's going to sign, this form. So they'll sign a new one every 30 days, initially and every 30 days. Okay, this one is a 5-page ITP, also has all of the requirements. So this one is going to go all the way across, however, and you're just going to use this one. So you have exercise, the initial assessment, the plan, home exercise, then you do your reassessment, another reassessment if the patient stays in the program that long, and then you have your discharge information. So it has all the elements for you. So if you have Scott Care, then you're good to go. Okay, wrong. That is a wrong statement. And I want to make sure that everybody leaves today knowing that I don't care if Scott Care spends $1 million on a format for us. And they've done a fabulous job of giving us good ITP formats. But the format is not the ITP, it's the detail. And so if you just simply check off the boxes that Scott Care gives to us, don't expect to pass certification, okay? And that has been, I think, the feeling of our membership, that they are responsible for giving us an ITP that passes. It is not their responsibility. It is not AACVPR's responsibility. It is our responsibility to make sure that we can tell the story of that patient as they go through cardiac rehab. Okay? So again, nutrition, other core components. It's a great start for an ITP. Okay, doesn't have to be Scott Care's ITP. You can have your own ITP, okay? This happens to be mine because it's what I had access to. Again, you can see in the reassessment, I have places where I can write every day because I think that that's important, that as you go through that you can document education, etc. So just an example, and that's what I wanted to do, just give you some examples of ITP that you can have. Okay, now as far as physician signatures go, I hear a lot of, well, how come, I mean, if they don't come 3 days a week for 12 weeks, then what do we do with the columns? I'm not a fan of the columns that much for physician signature, fan of the columns for documentation, but for physician signature, my doc starts signing at 21 to 22 days. I get him out there for him to sign because I know that he's going to make that 30-day deadline. So that's just one way that you can do your physician signatures. Okay, the devil's in the detail. Okay, that's what I was saying. The format is not going to get you there. This has all of the required check marks, has all the required labeling that you need for ITP, okay? It's got an assessment, it's got a plan, it's got interventions, it's got goals, it's got a reassessment, it's got discharge, okay? But, okay, again, all checks. But when you put the detail in, that's what is going to tell you how that patient progressed through cardiac rehab. Okay, makes sense? So that tells the story. The first one did not. Okay, same way with Scott Cares. Okay, that's great, has all the stuff in. And that's actually the same thing. I just took the format and then added the detail. Okay, so that's what I mean when if you just check the boxes, it's not good enough. You need to let us know what the story is. Okay, so what does the future look like? They're not going away. We're going to have ITPs. So you might as well embrace them and use them as a living, breathing document, okay? Make sure you're telling the story, and the performance measures that you're going to hear a lot more about, and I'm going to flip through these because we're kind of on a timeline here. You're going to hear a lot more about them later on today. Go to the session at 3:45, and you're going to get all the definitions of what these performance measures are. But I think that once you hear what they are, and you are able to incorporate them into your ITP, that's going to be a very good thing, because then it's going to be much easier to collect your data. Okay, so for instance, there's 4 for cardiac, and you're going to measure functional capacity. We almost all measure functional capacity anyway, and it's usually on our ITP. Okay, and so somewhere on your ITP, I would get it to where you can either do, and you don't have to do all of these, but they say you have to measure either by a 6-minute walk, a 6-limited stress test, or estimated peak METs. And they have criteria for how you do that, and that's what you're going to hear more about. But why you have to choose one way that you're going to measure that functional capacity for that patient. And then they give you the metric that they should be attaining in cardiac rehab. Okay, the second one is on blood pressure. We all take blood pressure, so this is going to be good. We're getting away from, or we're going, this is last year for behavioral, clinical, and health. Yay! Okay, yay. As a reviewer, I say yay. So these are the measures that you're going to have to measure and use the tools that they tell you that you have to use. Okay, so the measure is blood pressure control. Okay, so you're going to look at their blood pressure pre and post. I think it's on everybody's ITP already, right? Just like the 6-minute walk or however you do your functional. Okay, so nothing has to change, right? Okay, tobacco use intervention, that's the third one. It's not whether or not the patient starts smoking or stops smoking. All they want to know that you've completed an intervention with that patient, counseled that patient, sent him off for smoking cessation classes, whatever you end up doing for that patient that you've done. And guess what? That's the detail in the ITP, okay? Where you write in there, patient counseled on smoking behaviors or whatever you're going to put, okay? Depression's the last one for cardiac rehab. And with this one, they're going to give you the tools that you have to use, and you have no choice in that. You have to use the tools that they come up with, and there's going to be at least one free one with every single measure, so nobody's going to have to pay anything if they don't want to. Okay, and then that's going to be measured by a change in the severity of the depression. Okay, that's what they're going to measure. Again, put that on your ITP. We're good. For pulmonary, you guys are going to love this. Guess what? It's the ones you already collect. So it's going to be very, very little change for y'all in pulmonary. Okay, so they're going to give you the tools. That may be the only thing that changes for you. If you're not using one of the tools that they require, then you may have to change that. But pretty easy. Functional capacity is another one of the 3. There's only 3 for pulmonary. Okay, so it's going to ask you, and you have to use a 6-minute walk test. Nothing else. No shuttle test, no 6-minute walk. That's it. And then health-related quality of life is the third one for for pulmonary. And they're going to tell you the tools that you have to use. Okay, so just finishing up here, food for thought. Is your ITP updated regularly, and does it tell the story of that patient progressing? If the CMS auditors came into your program tomorrow And they said, please let me see your ITP, and Connie's going to talk to us a little bit about those Medicare audits, so they're real and that it happens. So will you be able to hand that ITP to that auditor and say, here it is, this is my patient's story? Because that's all they're going to look at, okay? Are you involving your patient and your family, and then can you easily adapt that to doing the performance measures? So with that, I have to end with actually the mouse one is my favorite. It says, 1, 2, breathe, breathe, breathe. He's dead, Jim. Love it. So anyway, with that, I am going to turn it over to my colleague Connie, and we are going to switch mics here. And
Okay, thank you, Barb. We're going to move on while they're switching microphones. I'll tell you a little bit about Connie Paladenech. Connie is a registered respiratory therapist, licensed respiratory care practitioner, and a COPD patient educator. She has won numerous awards, including the Founders Award from North Carolina Society for Respiratory Care, Award of Excellence and Distinguished Service Awards from the North Carolina Cardiopulmonary Rehabilitation Association, and the North Carolina Society for Respiratory Care Life Membership Award, and the American Association for Respiratory Care Fellowship. It goes on, but I'll skip down here. She looks like she's about ready to go here. She's a pulmonary rehabilitation program manager and ALS respiratory therapist at Wake Forest University Baptist Medical Center since 1999. She is also the cardiac rehabilitation program manager since 2004. She has served on numerous committees for respiratory care in North Carolina and is chair of the Chartered Affiliate Committee for North Carolina Society for Respiratory Care. She is well published in peer-reviewed journals and has written a book chapter in respiratory therapy. So at this time, I'll turn it over to Connie, and she's going to talk to you about pulmonary rehab.
Okay. Can you hear me okay now? Much better. Okay, all right. So what we're going to do is to try to go on a quick tour, really, of pulmonary rehab as related to the ITP, and we will close then with a review of some of the experience that we've had with our audits that we've experienced in the region that I'm in. It's something that we're all, at some point or other, going to be facing. So specifically, our learning objectives for this section are to describe current requirements of the pulmonary ITP. And I'm sure many of you are very familiar with those. And if you have pulmonary rehab, this is something that you probably should think about putting it under your pillow and sleeping on every night so that you stay up to date. And just for fun, out of curiosity, how many of you are doing pulmonary rehab in this group? All right, so we have a good number. That's wonderful. Okay, so we'll discuss some options for documenting patients' pulmonary rehab experience on the ITP, and we'll review some common reasons then for Medicare denials of our ITPs, and specifically talk about some tips for avoiding those denials. So first of all, what is an ITP? Well, as Barb said, it's a roadmap. and it's a summary of the planned care of our patient from the initial assessment to discharge from the pulmonary rehab program. CMS guidelines, as with cardiac, do require a physician's signature at the initial assessment before they begin their first exercise session, and then at least every 30 days thereafter, including discharge. Some of the elements of a good ITP is that it should be able to tell the story of each patient's journey through pulmonary rehab. And one of the things that I do as a review with my staff is we will just at random choose an ITP, and I'll give it to one of my staff that hasn't had a lot of experience with that particular patient, and then ask them to report to the rest of us about that patient based on the findings of that ITP. So it really gives us a roadmap of our patient's journey. And these are the North Carolina mountains, the Blue Ridge. So the ITP, we need to be sure that it does retain or contain the required elements that are required by both Medicare, by CMS, as well as by AACVPR if our programs are certified. We can use multiple layout options, and we'll look at some of those. So the style isn't what's important, it's the content that really matters. Another thing about ITPs is they should be easy for our staff to use. I think that probably every one of us now is experiencing an increase in referrals, so we're being asked to do progressively more with less. And one of the things with we're having to do that with increasing requirements for our documentation. And it's taking longer and longer and longer. And I don't know if your staff is like mine, but you did what? You changed the ITP again? Well, it's a living, breathing document. It is going to change, no doubt about it. So that's one of those things, just get used to it. But we need to be as efficient as we can. And that's one of the things, the advantages of using an electronic document that's well designed. It can make us much more efficient. The ITP also, if it's done well, should provide a continuum of care between healthcare providers. I think one of the things that we've experienced in our current healthcare system is there are so many separate places that patients visit. We tend to be in silos. So what we do in rehab really never gets communicated back to perhaps the physician office, or at least to that extent. We may send very good reports, but do they get read? A lot of times they're still, if they're on paper, they're still waiting for someone in the physician's office to file them in the chart. So it may be months before it actually makes it to the chart. So this is a way of providing that continuum of care. And as we're working together to share patient management so that we're moving the care to the most appropriate, least expensive area, it's going to be really important for us on the outpatient side to have an understanding of what happened while that patient was in the hospital. What are the physician goals? Where are they? And the physicians need to understand what we have done in pulmonary rehab. And actually, one of the things that I'll have to say, we had, and I won't go into it, but we had an epic experience beginning our EMR. We have Epic, and believe me, it was an epic experience. But one of the things that has resulted from that is a lot of our physicians now are pulmonologists, and what really surprised me is even some of our surgeons now, they'll call us back or they'll email us and say, well, I saw your note, and that patient is doing really, really good. Keep up the good work, or make these changes. So, and we're not even calling those docs and saying, sometimes we do, but they're contacting us. So this tells us that they really do care and they're concerned about what we're doing. So it's opened up a whole new channel of communication. And also that carries on over to home care. I'm going to run over these fairly quickly again in the interest of time. I think everyone doing pulmonary rehab should be intimately familiar with the 42 CFR, that's Code of Federal Regulations, 410.47, pulmonary rehabilitation. That's the one you need to put under your pillow. It is a broadly written document, and one of the things to keep in mind is that we're from all across the country here, which means that we have different Medicare area contractors, or MACs, that we have to work with. And the MACs are allowed some degree of interpretation in terms of how do we comply with those broadly written regulations. So what that means is what I'm doing in North Carolina that makes my medical director of my MAC happy might be a little bit different than what somebody else is doing in Seattle, Washington, or wherever else. This document, the 42 CFR 410.47, is also the regulators, the auditor's guidance for compliance expectations. And that, we've had some interesting experience with that in our current JM region. It was J11. We had quite a time. We went under Medicare audit for pulmonary rehab. Cardiac was first, and we'll look at that in just a few minutes. But we had an audit that lasted about 12 months or so for cardiac rehab. Medicare was doing a probe audit. Well, that was relatively painless. I won't say completely, but then there was pulmonary in the fall of 2012. That audit continued and continued and continued and continued. We finally had a celebration in March of 2015. In my program, we finally got the letter, the wonderful letter from Medicare that said, you are off audit. And it was, again, quite an experience. One of the things that we learned, and we'll talk more about this, but the auditors aren't always right, so they're not always the be-all, end-all. And one of our early on experiences was we had some pretty good documentation, but the auditors, the ratio, the FEV1 FVC ratio, the auditors were saying, well, it needs to be the percent of predicted for the ratio, not the actual ratio. So we had quite an experience there, and we wound up, among other things, having a face-to-face meeting with our MAC medical director. And that was one battle that I can honestly say we won. So some of the other things, very much in some ways similar to cardiac, the individual treatment plan is a written plan. It has to be reviewed by the physician every 30 days, and it needs to describe all of these things. These were the elements that our friendly MAC told us we needed to have. So we have to have the individual's diagnosis. We have to specify the type, the amount, frequency, and duration of items and services. And also we have to identify the goals that we set for that patient. They also define some of the elements of that plan. Outcomes assessment means a written evaluation of the patient's progress as it relates to the individual's rehabilitation, including the following: beginning and end evaluations based on patient-centered outcomes, objective clinical measures of effectiveness of the program for the individual patient, including their exercise performance, and also self-reported measures of shortness of breath and behavior. That was an interesting one. And they define who a physician is and who can sign off on the ITP. Oops. This is a disaster. Okay. Now, we're used to disasters where I come from. Okay, so physician-prescribed exercise, very similar to cardiac rehab. It means physical activity, including aerobic exercise, prescribed and supervised by a physician that improves or maintains an individual's pulmonary functional level. Their words, not mine. Psychosocial assessment means a written evaluation of an individual's mental and emotional functioning as it relates to the individual's rehabilitation or respiratory condition. And that's not necessarily one of the hard things for us to get our heads wrapped around when we were under the audits is our definition of a psychosocial assessment was not necessarily Medicare's definition of psychosocial assessment. And so we had some quite interesting discussions on that. Goals, patient progress, we've already talked about, and the effectiveness of the pulmonary rehab program for the individual patient. They want to know, Medicare wants to know if they're paying for it, that they're getting their money's worth. Dr. Feliciano's words, not mine, our MAC medical director, and a written evaluation of the individual's mental and emotional functioning as it relates to the individual's rehab or respiratory condition. Education or training, which needs to be clearly and closely related to the individual's care. What are their specific needs? We need to be sure those are documented, and again, that psychosocial evaluation and their rate of progress. What are the facilitators that patient has that will improve their ability to participate and progress in a program of pulmonary rehab? What are the barriers that we might expect to encounter? And how long do we think it's going to take us to get to where we need to go? And I really so much want to say on that when we have to specify the time, I want to say the rest of their lives, because this is not something that we're going to do for 12 weeks. We're trying to teach these folks a new lifestyle and new practices that they're going to be continuing for the rest of their lives. Measured and expected outcomes, the timetables, the exercise, again, those objective clinical measures. We need to document the progression of the patient over that 30-day period that we're reporting on, and again, a description of the individual's diagnosis. Now, as far as the ITP process goes, these are the required elements. We'll look at several different forms here in a minute, but the thing, as Barbara said, what's really important is not so much the style of the form we're using, but are the elements there? Does it tell the story of that patient's progress? What do they need? What do we plan to do about their issues? And what kind of progress are we making? The required elements for pulmonary rehab include oxygen assessment now, that's the newest one that's been added, exercise, nutrition, psychosocial, and then the other core components, which would be very specific to that individual patient. It might be their medication use, perhaps inhaler technique. It might be smoking cessation, but if they're not smoking, they don't need it. It could be airway clearance, but if they don't have a cough, they probably don't need a lot of education on airway clearance. And it might be teaching them awareness, managing their disease process, being aware of warning signs, danger signals that they might be having a problem, and how do they deal with those exacerbations. So those are the elements, but then we also have the steps that need to be conducted for each one of those elements, and this is the process. So we have the initial assessment, and I cannot tell you how important it is that we do a thorough initial assessment, because that's what sets the stage for the rest of the patient's journey with us in pulmonary rehab. Then we have to make a plan. We have to figure out what do we need to do. Then we have to make a plan. We need to set goals. And by the way, the patient, this is not just something that the pulmonary rehab team dreams up and pulls out of the air, but it needs to involve the patient. It needs to be meaningful to them, not just to us. Then what are our interventions or education? And then, of course, every 30-day reassessment, then discharge. And by the way, once the patient finishes, if you will, pulmonary rehab, what are the plans for his or her future? And then, of course, what were our outcomes? That's an area that we're going to be seeing increasingly more emphasis on. And one of the things that I would suggest that you do is just have a mental picture of no outcomes equal no income. So outcomes are going to be progressively more important. Okay, so how about the design then? Well, it has to contain all of those elements. The format, as we mentioned, it needs to be what works for your situation. And if you're getting ready to look at implementing an EMR, one of the suggestions that I would say is, or maybe multiple suggestions, learn everything you can about that system. One of the things that it took us a while to learn was, we had heard the word epic, and I have several definitions that I won't share with you today, but it took me a while. I had a number of friends who also had Epic, and their systems were different than mine. And what I learned was that there were different components. Our leadership would be the group who made the decision of, we're going to purchase this module and this module and this module. So the capabilities of the system I had might be a little bit different from the capabilities that another system had. So it's important, if you can, to kind of know that. And sometimes that information it isn't shared freely. So is your documentation, your ITP, is it going to be electronic? Is it going to be paper? Are you going to use a table format, a narrative format? What works best for you in your situation is the important thing. And what about those dreaded check boxes? Well, sometimes those check boxes are okay, and sometimes they're not so okay. So if it's just to identify a specific issue, such as a stage of change, and electronic gadgets hate me, I'm telling you. But it isn't appropriate if we're answering a question that has measurable data. We really need to know. So the example there, if we just check, yeah, they've got COPD. It means a lot more to me and to the patient if we can say, yes, the patient does have COPD, gold stage 3, they are, or actually it should be 4 if they're oxygen dependent. So all of those things we need to have some narrative so we know what's going on. Okay, this is an example of one of the ScotCare EMRs that is coming out, and just like with cardiac, there will be a short version of this and a long version of this. The actual numbers in there are pretty much just placeholders, so don't critique the specific numbers. But I think you can get some idea of the format. And notice this one is just oxygenation. So first of all, in the left-hand column, we have, and I don't mean to not talk to you guys over there, we have our assessment, then we have our plan, and then our reassessment every 30 days. And then, of course, the follow-up discharge plan. And pretty much all of the other elements follow that same format. I'm just going to flip through so you can, again, get some idea. But anytime you can enter a number, it's important. And by the way, you need to also have some narrative to address what are you going to do with that number? What does it mean? It has to be more than just a number. This was something that got a lot of the programs, pulmonary rehab programs in my region, in trouble because we were so used to being efficient, and it made good sense to us, but unfortunately, when we just said the RPD is 6, it didn't mean that much to the auditors. They wanted us to tell them more. Okay, so I'm going to flip on through there. And this is the psychosocial, okay, the summary. And this is the form that we're currently using. We have a face sheet. This is where we document our education. This is our oxygen assessment, and a number of the others. I'm going to flip on through so that we can go ahead and move on. Okay, this is, again, our exercise. Okay, and then our signatures. Now, one of the things that we had to adjust was with the EMRs. I haven't really been able, there is one way, but we had been having all of our team sign off on the ITPs every 30 days. And by the way, in the words of our medical director, he said, the rules are very clear. It does say every 30 days. It cannot be 31 days. It can't be more. It can be a few days early to have it signed. But it does have to have the physician's signature. So really with the ITP, what we really need on that is the physician's signature. Okay, so on to the denials then a little bit. Some of our major reasons for denials were that the Medicare audit contractors these are their instructions. And if services, in their view, don't meet these guidelines, they're instructed to deny them. So you can sort of see what they're looking at. Now, for cardiac rehab in the Carolinas and the Virginias, these were the most frequent denials. So the cardiac rehab sessions didn't include the required services. There wasn't documentation of physician-prescribed exercise, or cardiac risk factor modification, or psychosocial assessment, any of those things. The physician must be readily available. And that was one of the things that we weren't doing, everybody. We weren't including the name of the supervising physician on our daily notes. Cardiac rehab not warranted for the diagnosis. And the requested records not submitted timely. Now we have 45, at the time of this audit we had 30 days. Now we have 45 days from the date on the letter, the ADR or additional documentation request, and it's not the date that you receive it, it's the date that they wrote it, that they start the clock on to respond. Okay, for pulmonary rehab, this is just a summary of some of our audit experience. Documentation didn't have the required components. Pulmonary rehab not warranted for the diagnosis. And one of the big things is, if you remember, when we say pulmonary rehab, we're not talking pulmonary fibrosis here, we're talking COPD. And it has to be the old gold stage 2 through 4. And by definition of the gold standard, that diagnosis is made based on the post-bronchodilator spirometry. Many programs were having pre-spirometry rather than post, and of course, pre and post spirometry costs about double the cost of just spirometry. So in the interest of saving money, a lot of folks were just getting pre. But that's not good enough for Medicare. Okay, so we didn't include required components, and you can see different timelines here and how our percentages work. They give us a summary quarterly, every 3 months. No order referral, requested medical records not submitted timely, services not documented. If we provided more than 36 visits, they wanted to see that KX modifier on there. And one of the big things, and this is another plug, Scott Care with their ITPs have helped a lot. One of the reasons for requested medical records not submitted or not submitted timely or missing elements is you might have, the page might be there, but in the process of faxing or emailing the ADR request, what may happen is it may not be legible. And in Medicare's view, if they can't read it, you could have the best documentation in the world, but it's just not there. So that was a part of the problem. So in our region, no post-bronchodilator spirometry, misinterpretation by the auditors, psychosocial narrative, missing elements, and sometimes we had check boxes that were just, as Barbara mentioned, check, check, check. That didn't fly very well. So these were our reasons for denial. Documentation didn't include required elements. The service wasn't warranted. Supervision not documented, or services. And again, all of those things that we mentioned. Some of the specific denials, there was no psychosocial assessment. That was one of our biggest challenges because our definition in rehab and Medicare's definition of psychosocial were a little bit different there for a while. I think we've pretty well cleared that up. There is no outcomes assessment, no physician prescribed exercise, no documentation of education or training. Not warranted for diagnosis. I think I've said enough about that one. That was the biggest thing that got us in trouble there. Okay, physician must be readily available. We're required on each of our daily notes to indicate the supervising physician. Specific no order or referral for services not documented. Auto denial, requested medical records not submitted. Sometimes we learned that was our problem. Maybe the ADR request went to your HIS department and didn't even make it to cardiac or pulmonary rehab. KX modifier. So some of the tips that I would suggest, if you have, and let me just ask very quickly, how many of you have been audited? Okay, you lucky people. But let's hope you're not. So I think one of the big things to remember is actually the ITP is one of your best, it can be your best friend and your best defense if you are audited, if you take the time and do a thorough job. And this is one of the things that I think has been really, really good about the ScotCare ITPs because those elements are there. The other thing is that they've been great about customizing those ITPs to meet our specific program needs. So know your MAC, and AACVPR has assigned specific liaisons. So you can actually go on the AACVPR's website and find out if you don't already know who your MAC representative is. Be sure that you're familiar with the CFR 42.410 and any LCDs that your local MAC may have. Your best defense is a good offense, but keep in mind that the MACs may have their own interpretation of some of the rules, and they do have the right to do that. So be sure you understand what they're asking for. If you do think you're right, don't hesitate to appeal. And also keep in mind that the auditors for the MACs do not all have the same level of training. So don't hesitate if there are questions. And one of the things I would strongly encourage you to do, if you are involved in an audit, contact your MAC representative from AACVPR. They can be really, really helpful in guiding you through that process. And as we learned from our MAC, they listen much, much better to AACVPR or our state organizations than they do to us as an individual. So really, this is another reason why it's so important to be so involved and up to date with AACVPR. So With that, I'm going to close and give you a chance if you have any questions or comments. Okay? Okay. Yes. On a little, right. Okay. Well, one of the things that our MAC wanted, and we've been able to get them to simplify it maybe a little bit now, but we had all been, and when I say all, I'm talking about cardiac and pulmonary rehab. In the Carolinas, we tend to use Ferens and Powers Quality of Life Survey as one of the documents that's frequently used. We use the cardiac version or the pulmonary version, depending on the patient. So what we were doing is, it told us, we knew what we were talking about, so we just had the scores down. So for our baseline, or our initial assessment, we had the scores for all of the domains. Okay, and then we did the same at the end and the change. Well, there were a couple of things. Number one, Medicare wanted to know what did those scores mean. Number two, what did you plan to do with those scores? Okay, and number three, did the patient make progress? Another thing that they were more interested in, they really didn't care. It was fine if we mentioned the patient had depression, whatever, but what they really wanted to know is what were the things about that patient, their family, their living conditions that might either facilitate or impair the patient's ability to participate in and benefit from a program of pulmonary rehab in this case. So they were really more interested in that, not so much a psychological or psychiatric diagnosis. They didn't care that the patient had schizophrenia or whatever. They wanted to know, do they have transportation? Are they blind? Whatever. Does that help? Okay.
We have just a little time for a couple more questions here. Does anybody wouldn't mind? Let me get you the microphone so we can hear the question.
Could you just explain, you said they wanted the pre and post bronchodilator, and so is that just the initial when they first come in, or were you saying they wanted a post
they wanted
test
both.
at the end of the
Actually,
program?
Good question. Okay, with spirometry, keep in mind you can do either just baseline spirometry or you can do pre and post bronchodilator spirometry. So basically for the assessment, in order, and if you follow the GOLD guidelines, you cannot say, well, you've got COPD, GOLD stage 2, 3, or 4, unless you have that FEV1 and the FEV1 FVC ratio, okay? You've got to have those, and they have to be obtained post-bronchodilator. There's nothing that says that we even have to do spirometry post-rehab, but they do want to see that. We can't technically say you have COPD unless we have that.
Unless it's done post-bronchodilator at the initial onset.
Yes.
Okay, thank you.
Uh-huh.
Okay.
Question for Barb. You had mentioned there's only approved studies that we can list for quality of life, depression. What if before I used like Dartmouth Quality of Life Index because I was using COOP at the same time for pulmonary versus cardiac. Do we have to use these listed ones now at this time?
For when you, yes, they're going to give you the tools that are acceptable tools. And they're acceptable because those are validated tools. So the expert panel's gone through each one of those and vetted them out. And like I say, there will always be at least one free one in there. But if you're using something else, then you need to switch.
They were acceptable tools given to us about 4 years ago, I think, in Los Angeles. Are those going to be changed?
Perhaps.
Outcome tools? Okay, so they might be changed.
These were just vetted this past year.
Okay.
So definitely don't miss that session at
So they might
3:45 today.
Thank you. Can I also ask, I've heard that AACVPR is looking for lots of physician comments on the ITP, so that physicians shouldn't go through every 28 days and sign off. There should be some comments on specific patients. Is that what you're looking for?
Well, that would be lovely.
That would be nice. It's not expected, though.
This is more from our MAC, which happens to be JM now for the Carolinas and Virginias. They tell us that the physician's signature must be there, but we must be able to demonstrate physician involvement. So it does help to have a note, but there's nothing that specifically says that the physician has to write a note. But they have to agree that, yes, we continue with the plan that we've made, or we need to make certain modifications.
Could you please tell me, like on a PFT, if a patient has had one done previously before, is it good for a year, 6 months, or do they need a current one when they start rehab?
Okay. Wow. It depends. All right. Again, this is for our MAC, and I would tell you that's one of those things, if you have an LCD for your state, make sure you're familiar. If you don't, then you're kind of open. But what our MAC tells us is there is no specific time frame, but it must be medically relevant. So as long as it's medically relevant, if from 2 years ago, whatever, you have a post-bronchodilator study and it's medically relevant, then that is acceptable. Now, your medical director, your institution may have some other guidelines, and if so, I would certainly, and for good practice, I would certainly encourage you to follow those.
Okay, we're going to have to move on here. If you have some questions, maybe our speakers can stay a little longer and you can ask your questions. I know there were a couple more here. Thank you all for attending, and have a good time here in New Orleans. Thank you.
Thanks.
Thank you so much. We have a